We're in the fortunate position now for patients with CLL that at different points when they're coming up to requiring therapy, that we've got the luxury of choice of therapies for these patients. And certainly in the UK setting, we often do have a dilemma or a choice as to what's the best treatment option for the patient. And I guess we need to think about the patient in a holistic perspective, and some of the choices that we might make would be based on efficacy and whether treatments will be just as efficacious if the patient's low risk or high risk, but also from the toxicity side of things, and kind of where you tip the balance in favor of whether you're going to base your choice more on efficacy or toxicity kind of depends on whether that you'd consider them low risk or high risk. So for example, a patient that has very low risk disease, that they've got IGHV mutated disease with no poor prognostic features, you may, and they're young, potentially you may consider a fixed duration therapy, so a venetoclax-based regimen for that patient, rather than committing them to continuous therapy if they don't have any high risk features. Whereas the same young patient, if they had poorer risk factors, you may consider continuous therapy for those patients.